All right, let's look at our agenda for today. We're covering Section 1, Principles of Liver Resection. Section 2, Diagnosing Benign Liver Tumors. Section 3, Hepatocellular Carcinoma, or HCC. Section 4, HCC Treatment and Transplant. And Section 5, Metastasis and Other Cancers. Let's get right into it.
Section 1, Principles of Liver Resection. Okay, before we even think about talking about tumors, we got to talk about how to safely cut into the liver in the first place. The absolute biggest principle here is bleeding control. Since most bleeding during resection actually comes from the hepatic veins, surgeons have to maintain a remarkably low central venous pressure. We're talking under 5 millimeters of mercury, and they severely restrict fluids to keep the operative field safe. But the real deciding factor for surgery, it's knowing exactly how much liver we can safely remove.
Which brings us to the real deal breaker, functional liver reserve, or FLR. Now, the liver is famous for its ability to regenerate, right? But you still have to leave enough healthy tissue behind to keep the patient alive while it does that job. This is absolutely critical in cirrhotic patients because their cellular regeneration capacity is already severely blunted.
Look at this stark mathematical contrast. According to the surgical texts, if your FLR is over 50%, you're looking at a very low risk of postoperative liver failure. But if you dip below that 20 to 25% threshold, your surgical mortality literally skyrockets. You just simply cannot resect a liver if that remaining fraction can't sustain the patient's life. And here is how we actually plan these surgeries radiologically using the LIRAD scoring system, which comes from triple-phase CT scans. This is a massive, high-yield topic for surgical exams. It's actually a lot like the BRAD system used for breast imaging. LIRADS categorizes risk perfectly, scaling all the way from 100% benign at LR1 straight up to 100% definite hepatocellular carcinoma at LR5.
Section 2, Diagnosing Benign Liver Tumors. Moving on to the benign stuff. Now, most of the time, these are just incidental findings. A patient gets a scan for something entirely different, and boom, there's a liver mass. However, they carry distinct, highly testable features that dictate whether we just observe them, intervene, or start to panic.
So you need to lock in these exam one-liners for the big three. First up, hemangioma. This is the most common benign liver tumor overall. On a CT, you're going to see peripheral nodular enhancement that slowly fills in. Second is FNH, which uniquely features a classic central stellate scar. And third is hepatic adenoma. This one has a massive association with oral contraceptive pills and requires incredibly strict monitoring because of its rupture risk and a roughly 10% risk of malignant conversion.
But actually, scratch that. Don't just rely blindly on textbook definitions, because in 15% of FNH cases, that classic central stellate scar, which by the way is actually just a dilated central artery radiating outward like a spoke whale, is totally missing on the scan. When that happens, it's virtually impossible to distinguish it from cancer on imaging alone, which forces you to do a biopsy to rule out HCC. Oh, and a quick fun fact, because FNH contains Kupffer cells, it will uniquely show up as a hotspot on a sulfur colloid scan.
To really understand the gravity of hepatic adenomas, listen to this cautionary tale straight from our source material. 2 teenage girls were put on long-term oral contraceptive pills for PCOD, and they didn't follow up for years. Eventually, they presented with hepatomegaly. That unmonitored OCP use triggered multiple hepatic adenomas in both of them. One girl required a massive liver resection, and the other? Her disease was so extensive across both lobes, she actually required a full liver transplant. It's a crazy story, but it perfectly illustrates why prolonged OCP use demands strict medical supervision.
Section 3, Hepatocellular Carcinoma, or HCC. Let's see how all this knowledge builds as we face our primary antagonist. The incidence of HCC is unfortunately climbing. And while alcohol, hepatitis C, and increasingly NASH are major risk factors, our source makes it very clear that hepatitis B remains a primary driver of this worldwide.
When imaging suspected HCC, this is the binary contrast you absolutely must know to tell it apart from a liver metastasis. Because HCC gets its blood supply primarily from the hepatic artery, it is uniquely hyperdense, meaning it shows up bright in the arterial phase. But in the venous phase, the contrast leaves the tumor way faster than the surrounding liver tissue, creating this classic rapid washout effect. Metastases, on the other hand, just stays hypodense. Let's rapid-fire some high-yield HCC facts for the boards. It is the most common primary malignant liver tumor. Patients typically present with a hard, palpable liver margin. That's hard hepatomegaly. Interestingly, jaundice is actually a late sign. And you really need to watch out for the paraneoplastic syndromes. While hypoglycemia is the most common clinical paraneoplastic syndrome, hypercholesteremia is specifically the most common biochemical one. Section 4, HCC treatment and transplant. So how do we actually go about treating this? Well, everything depends on assessing surgical mortality before we make a single cut. We rely heavily on the Child-Pugh score, where, for context, a C carries a grim 70% surgical mortality, and the MELD score. These help us efficiently separate the patients with resectable, localized disease from the ones who need complete alternatives. Now, for patients with inadequate functional liver reserve who just wouldn't survive a resection, a liver transplant is literally a lifesaver. But, as we know, donor organs are incredibly scarce, so patients are only eligible if they strictly meet the Milan criteria. That means a single tumor under 5 centimeters or up to 3 tumors, each under 3 centimeters, with absolutely zero vascular invasion and zero distant spread.
But what happens if they don't meet those Milan criteria and their FLR is simply too low for a resection? This is where it gets incredibly cool. Surgeons use this brilliant biological hack called the ALPS procedure, or the Nimmer technique. Basically, they intentionally embolize the portal vein that supplies the site of the liver with the tumor. By cutting off 80% of the blood flow to that diseased lobe, it literally forces the healthy opposite side of the liver to undergo compensatory hypertrophy. You wait just 2 weeks, and that healthy side grows enough to give you an adequate FLR, and then you can safely resect. Incredible, right?
For intermediate multinodular disease that we can't resect, we get creative with the liver's plumbing. We know HCC feeds mostly from the hepatic artery, so we thread a catheter right into that specific artery to hit the tumor directly. We use TAS to choke the blood supply while hitting it with chemotherapy, or we use TARE to inject radioactive yttrium spheres directly into the tumor bed, basically shrinking it from the inside out.
If the disease advances even further, like, say, we start seeing gross vascular involvement or portal invasion, those direct surgical tools step aside for targeted systemic therapies. We might use sorafenib, which is a tyrosine kinase inhibitor, or deploy immunotherapy agents like nivolumab. Sadly, if a patient reaches stage D with a Child-Pugh C-score, our treatment shifts entirely to palliative care.
Section 5, Metastasis and Other Cancers. Okay, we thoroughly covered primary tumors, but here's a quick reality check. The absolute most common malignant liver tumor overall? It's not HCC. It's actually metastasis from other organs. And that brings us to the final, highly aggressive section of this explainer.
Hold on, right before we completely leave primary HCC behind, we gotta mention this absolute favorite exam curveball, the fibrolamellar variant. This one breaks all the standard rules. It hits young patients with totally healthy, non-cirrhotic livers. Even weirder, their standard alpha-fetoprotein levels are usually normal. Instead, you have to look for the marker neurotensin B. And while it is highly resectable and has a pretty good initial prognosis, be warned, it carries a stubbornly high recurrence rate.
All right, shifting to metastasis, specifically from colorectal cancer. The modern surgical approach here has become unbelievably aggressive. It used to be that if a patient had more than 4 liver lesions, surgery was completely off the table. Not anymore. Today, as long as the disease can be completely resected while leaving an adequate FLR, surgeons will operate. Why? Because aggressive resection radically prolongs survival. They'll follow that up with 6 months of adjuvant chemotherapy and hepatic artery FUDR infusions to keep that recurrence rate down.
Finally, let's round this out with 2 other major players you need to know. First, intrahepatic cholangiocarcinoma, a cancer of the biliary tree. The tricky thing here is that jaundice is a surprisingly late sign, mainly because the tumor arises way out in the periphery of the liver, not in the center. Second is hepatoblastoma, which is a tumor of fetal hepatocytes and is actually the most common primary liver malignancy in toddlers under 3 years old. It's also strongly linked to familial adenomatous polyposis, or FAP syndrome.
So, as we've seen in this fast-paced explainer, the field of hepatic surgery is just relentless. From literally hacking the body to force the liver to grow using the ALPPS procedure, to aggressively chasing down colorectal metastases that used to be an automatic death sentence, surgical boundaries are constantly falling. Which leaves us with a truly exciting question. What traditional medical rule are surgeons going to rewrite next? Thanks so much for hanging out with us, and keep learning.